can all get ready. Let us pray. Dear Heavenly Father, we come before you today and ask for your presence with us as we begin this meeting. We pray for wisdom and understanding as we discuss the topic at hand. Help us to communicate effectively and listen attentively. May your guidance be with us throughout this meeting, and may we be open to your direction and leading in all that we do. We pray for protection and safety of all gathered here, as well as their families, and keep us safe from harm, and may your love and grace be with us always. We pray all of this in Jesus' name. Amen. So our speaker tonight is Dr. Nicholas Burrows, and that's Burrows with an E-S, and he's a consultant neurosurgeon and spine surgeon. Dr. Burrows completed medical school at the University of the West Indies. Following his internship and 3 years of general surgery at the Princess Margaret Hospital, he specialized in neurosurgery, completing the postgraduate program in 2017. Dr. Burrows completed extensive neurosurgery training at Cornwall Regional Hospital in Montego Bay, Jamaica, the University Hospital of the West Indies in Kingston, Jamaica, and the Royal Melbourne Hospital Department of Neurosurgery in Melbourne, Australia. Additionally, he enhanced his expertise in spine surgery after completing an orthopedic spine surgery fellowship at the Macquarie Institute Hospital in Sydney, Australia. Dr. Burrows is also an international member of the Congress of Neurological Surgeons. In February 2022, Dr. Burrows joined the Princess Margaret Hospital's team, where he serves as a consultant neurosurgeon and provides expert care to both adult and pediatric patients with brain and spine disorders. So welcome, Dr. Burrows, and imagine that you have a rousing round of applause going on right now as you take the stage.
Okay, thanks a lot for the introduction. Thanks, Dr. Shea, for inviting me to speak on this topic. Do recognize that the majority of the participants are non-medical, and so I've tried to tailor this presentation to suit that fact. Brain cancer is among one of the most deadliest cancers that we know of, and is a source of substantial disability and morbidity. So it makes this topic an important one. So let's get right into it. So over the course of the presentation, I'll be giving an overview on what's brain cancer, a few definitions, the possible causes, signs and symptoms, what we as clinicians utilize to diagnose the condition, and the treatment options that exist. So we often hear the term tumor. So what's a brain tumor? It's an abnormal growth of cells within the brain or tissue line in the brain. We call this the dura. When growth is, growth which is benign or malignant can occur. So brain cancer in and of itself is malignant growth. The growth is rapid, can invade normal tissue, spread to other areas of the central nervous system. Spread to other areas of the body tends to not occur in brain cancer. Brain cancer could be primary or secondary. Primary meaning it arises from native cells within the brain. Two main classes of cells, neurons and glial cells, which are the supportive cells of the brain. Secondary cancer is cancer which originates outside of the brain and spreads to the brain. We often know this as metastatic brain cancer. So in terms of primary brain cancer, the most common type is a group called gliomas, particularly astrocytomas. As mentioned before, it develops from glial cells. We may hear the term grade sometimes. Grade really refers to the level of aggression of the cancer. So it could be low grade, less aggressive, slower growing, lesser degree of normal brain invasion, or high grade, more aggressive, rapid rate of growth, greater extent of brain invasion. Primary brain cancers represent about 1% of all cancers. It's highly lethal. About a third, in general, about a third are alive after 5 years. In kids, most common solid tumor. It's a leading cause of cancer-related deaths in males less than 40 years. and females less than 20 years. It was estimated in 2021 that approximately 25,000 brain and central nervous system cancers would have been diagnosed, with approximately 19,000 estimated to die. Unfortunately, data thus far is limited in terms of what we have available to predict what we'd expect in the Bahamas. So glioblastoma, this is a type of glioma which is highly aggressive. It's actually one of the most lethal brain cancers that we know of. Represents about 54% of gliomas and 16% of primary brain cancers on a whole. Less than 5% of patients tend to be alive after 5 years of diagnosis. Unfortunately, literature suggests that the most common time frame for persons to survive is approximately 15 months. In practice, I've really seen 8 to 12 months survival at best. In the US, 3.4 per 100,000 persons are diagnosed with glioblastoma, with the most common age for diagnosis is 64 years. Tends to be uncommon in children. The peak incidence for glioblastoma tends to be around 70 to 80 years of age. It's more common in males than female, but only by a slight amount. More common in Caucasian males. Tends to be less common in African countries, but most common in European countries. Over the past 40 decades, minimal significant advances in terms of prevention, early detection, or treatment has occurred in this disease. So you can see it's one of the most significant cancers we have to deal with, but very little options in terms of changing outcome has occurred over time. But what the figures that I was able to ascertain from the cancer registry we have here was from 2018 to 2021. There were about 23 cases of primary brain cancers diagnosed, 10 being male, 14 being female. 16 were gliomas, or 69% of them. 10 cases were glioblastomas, and of those 10 cases, 4 were males, 6 were females. It somewhat compares to world figures. The only difference is that based on the figures we have here, it was more common in females. You can see the opposite in literature. That we know of, less common than the glioblastoma include oligodendrogliomas, malignant ependymomas, medulloblastomas, diffuse brainstem gliomas, choroid plexus carcinomas, CNS lymphoma, germ cell tumors. These terms might seem quite big to the non-medical participants. So I don't want you to be concerned about them, but it's still worth mentioning. In children under 15 years, brain cancer represents the second most commonly diagnosed cancer behind leukemia, about 21%, while leukemia is 28%. 15 to 19 years is actually the most commonly diagnosed cancer, 21%. Medulloblastomas, ependymomas, and brain cell gliomas I mentioned before occur more commonly in childhood. Glioblastomas almost is very, very rare. Now, as it pertains to metastatic brain cancer, overall it's the most common brain tumor, 55% of cases. Persons who have a cancer somewhere else in the body, about 15 to 30% of them will have spread to the brain at some point. Most common sources include the lung, 44%, breast, renal cancer, next in line, gastrointestinal cancer, and about 10% of patients we can't really identify where the cancer is coming from. In children, sources of spread include neuroblastomas, rhabdomyosarcoma, Wilms tumor. Just a brief word on each. Neuroblastoma is a primitive nerve tissue outside of the brain and spinal cord. Most common site where this cancer could occur is adrenal gland, and it could spread to the brain. Rhabdomyosarcoma, a soft tissue type of cancer originating in muscle. Wilms tumor is a rare kidney cancer affecting many kids. So what are the causes? Truth is, there's no real direct cause that has been identified over the years. There may be some factors which could increase the risk of developing brain cancer, but the only one really that has shown some amount of correlation in research has been exposure to ionization radiation, which is treatment, whether for some cancer outside the brain or the brain itself, exposure in the workplace, imaging studies, repeated imaging studies such as CT scans and X-rays, primarily CT scans. There is a group of compounds called N-nitrous amines. It's kind of controversial, their role in the causation of brain cancer. They may be present in certain foods, beverages, tobacco, pesticides, herbicides, fertilizers, groundwater contamination from disinfectants. The trace amounts in foods and beverages allow for some researchers to not necessarily find any link to or any risk factor in the development of brain cancer. However, because it is well known that certain values of N-nitrous amines can be carcinogenic, it's worthwhile noting that this might play a factor in the development of the disease. Other risk factors: increased age. As persons get older, particularly over the age of 60, the risk of development of primary brain cancer, mainly glioblastoma, develops. It peaks at about 8 years. Male sex, as I said before, slightly more greater incidence compared to females. The Bahamas figure could be concerning. Females tend to be diagnosed more than males. Inherited diseases such as neurofibromatosis type 1 and 2, Turcot syndrome, Lafreniere syndrome. With these, just a brief note, neurofibromatosis type 1, we recognize it as individuals with a lot of spots and lumps on the skin. Von Recklinghausen's disease is the other term for it. With those persons, they can develop astrocytomas, optic gliomas, along with the neurofibromatosis. With Turcot syndrome, very rare. You can have multiple colorectal neoplasms along with astrocytomas. Lafreniere syndrome, also very rare. You can have adrenal cell cancers, breast cancers, as well as astrocytomas. So, famous question: do cell phones cause brain cancer? Extensive study research has been done in this area. Many different agencies, FDA, FCC, CDC, no causation between or link between cell phones and brain cancers have been noted. Cell phones do emit radio frequency radiation, hence the concern. However, it's not deemed to be in sufficient quantities or levels to produce the disease. So what are the signs and symptoms? It's probably thought that brain cancer would, persons would show up to the emergency department in a coma, or significant alteration in conscious level. That's actually the less common way of presenting. The most common way is just present progressive neurological deficits, about 70% of individuals. Headaches, next, and seizures, 50 and 30% respectively. I think that before going into the neurological deficits, I'll just do a brief or simple review of some brain anatomy so we can understand how these deficits occur. So, simply put, the brain is a command center of the body. We have the frontal lobe, deep to the skull, the front of the brain, responsible for higher function, thinking, intellect, personality, judgment, social appropriateness, voluntary movement, language. There are two frontal lobes, left and right. Left controls the right side of the body, right controls the left. And about 95% of individuals or more, you can have a dominant side being the left side, where language language control is present. The parietal lobe, sides of the head, or near the top, near the crown, essentially that's responsible for us having a sense of our environment, sensation, touch, other functions it forms a role in terms of us understanding language, writing. Really, it's our ability to interact with our environment and our environment interacting with us. The temporal lobe at the sides of the heads as well, just below the parietal and frontal lobe, just above the ears if you wanted to have an understanding where it might be located. It's important in generation and formation of memories, emotion. The visual pathway passes through the temporal lobe. So it's a quite important organ in terms of us being able to see things, know things, recall information. The occipital lobe at the back of the head, it's the visual cortex, left and right. And I should say, just like the frontal lobe, the parietal lobe, left and right side, temporal lobe, left and right side. So likewise, occipital lobe, left and right side controls right side controls the left. Responsible for us being able to see our environment. The cerebellum, just below the occipital lobe, peer structure as well. It's at the back of the head, controls and regulates motion, helps to make our voluntary movement smooth and not jerky. That's one of the main functions. The brain stem, just in front of it. This is the geographic center of the brain. Really would connect, the entire cerebral hemisphere, left and right side, as well as the cerebellum to the spinal cord, which starts below and carries information from the body through the spinal cord to the brain, and from the brain to the spinal cord and to the rest of the body. There's a small gland at the base of the brain. I hope you can see my cursor, referred to as a pituitary gland. Tumors in this area tend to be benign, so I won't really speak much about it. But rarely you may have a pituitary cancer. If that should happen and it grows and it's invasive, it can affect the optic nerves, which lie just above the pituitary gland. It can have hormonal disturbances, but that I won't speak much about the pituitary gland, pituitary tumors in this discussion, since the majority of them are benign. This is just two pictures, cadavers, the brains of cadavers. The picture on the right shows our brain from the side view. You can see the cerebral hemisphere, temporal lobe on the side, frontal lobe in front, parietal lobe on top, occipital lobe behind, cerebellum below, and looking at the brain from the base, there's the pons, and you'll have the midbrain above, and you'll have the medulla below. All of that forms the brain stem, the center of the brain. Going towards the spinal cord, you'll have the temporal lobes, left and right side, frontal lobes above, cerebellum below. So, neurological deficits, as said before, depends on which area of the brain is involved. So as cancer grows, it can compress, invade, destroy normal tissue. So depending on which area it involves, that will be the neurological deficit that one might see. And we'll go into the other signs and symptoms which can occur as this growth progresses. So with the frontal lobe, the person could demonstrate personality changes, confusion, dementia, not knowing the time, place, person who's talking to them, hemiparesis or weakness on the opposite side of the body. They could lose speech or the inability to communicate, which involves the left side. There is a small percentage of persons, less than 5%, where the right side is a dominant hemisphere. So if you have a tumor in the right frontal lobe, depending on where it is, language could be affected in those individuals. The parietal lobe, also, they can have difficulty in understanding language, can have confusion between the left side and the right side of the body if the dominant hemisphere is affected. If sufficiently large, weakness could also occur on the opposite side of the body. There's loss of sensation on the opposite side of the body, as well as visual disturbances. As it pertains to the temporal lobe, you could have hallucinations, hearing things, smelling things which aren't there, impaired memory, deja vu, visual impairment as well. Occipital lobe, visual deficits mainly, cerebellum, difficulty walking, keeping balance, tremors with movement, double vision, nystagmus, this is like a side-to-side or jerky movement, involuntary of the eyes. All of these signs or symptoms can be demonstrated in persons with tumors or brain cancers involving that area of the body. As it pertains to the brainstem, like I said, everything has to travel through the brainstem to or from the brain. Brainstem is also important in controlling movement of the eyes, movement of the face, swallowing, respiration, cardiac function or heart function. So depending on where in the brainstem is affected, it could have weakness of the face or the limbs, difficulty walking, keeping balance, vertigo or dizziness, double vision. You could have respiratory impairment, nystagmus in kids, failure to thrive, especially if they're less than 2, or poor swallowing. Now, headaches, about 50% of patients with brain cancer will show headaches. It might be the only initial symptom. Typically, it's worse in the morning or bending forwards, worse with straining or coughing. 40% of persons with brain tumors on a whole may have nausea and vomiting associated with the headaches. And when they vomit, temporary relief of the headache may occur. So if a clinician was to be asking them about the headaches, these would be questions to definitely ask the patient. Any onset of new headaches in persons above 50 warrants medical evaluation, or additionally, persons who are chronic sufferers of headaches like migraines are known to have them. If there's any significant change in the character of the headache, that also warrants some amount of medical evaluation to make sure that something more serious or sinister is not occurring. What are the causes of headaches? Raised intracranial pressure, primarily, could be due to the tumor mass. The tumor, as it grows in size, compressing the brain, surrounding brain swelling, hydrocephalus, commonly known as water on the brain, or bleeding into the tumor. You could have invasion of the dura, pain-sensitive structures of the brain. Blood vessels being invaded could also cause pain. Extreme or high elevations in blood pressure. This can be a compensatory response to the high intracranial pressure that can also cause headaches. Person just by having double vision or diplopia can result in headaches, or just the psychological stress of worrying that they have a brain tumor or seeing themselves becoming weak, having neurological deficit. That in and of itself can produce worry, resulting in headaches. About 30% of patients can actually present with seizures. First-time seizures in a 20-year-old should be investigated, and a brain tumor should be high on the differential. Seizures could be focal or generalized. Focal meaning it occurs in one area of the body, like a single limb. Generalized, the entire body is involved in the seizure, often associated with loss of consciousness. Other signs and symptoms to be aware of: blurred vision, which can occur with the raised intracranial pressure, affecting the optic nerves of the eyes. Stroke, they could actually resemble somebody who has a stroke if they come into the emergency department. That stroke could be, just transient. We call it transient ischemic attack in medicine. Could just be a momentary loss of consciousness, right? Or just simple tingling or abnormal sensation in the limbs. But essentially, persons may be thought to have had a stroke, but it really turns out that they have a brain tumor or brain cancer. Kind of mental status changes, confusion, lethargy, depressed conscious level. In kids, one of the signs is that the head just keeps getting bigger and at a rapid rate. That should alert someone that something is happening and the kid should be investigated. At the top of the brain, there's a little area, persons will know it, bulging fontanelles that can occur, and irritability with infants as their sign that they're having headaches. So how do we diagnose it? Simply put, based on signs and symptoms, past medical history, particularly if they have a history of cancer somewhere, they can present now with brain cancer as a spread to the brain. Investigation primarily is imaging, CT scan plain or with contrast, a special dye that's injected. It's radio opaque or shows up as white on the scan, can illuminate the tumor. MRI with and without contrast, spectroscopy, MR spectroscopy, looking at certain types of metabolic substances within the brain that can also give an idea as to what type of tumor. PET scans tend not to be used commonly in the diagnosis of cancer. However, it might be useful where a patient is being screened for cancer somewhere else, and you want to determine whether or not they have small metastases to the brain which are not readily visible on CT or MRI. Adjunctive blood tests can also be important. Complete blood count, ESR, CRP, renal function test, electrolytes. Primarily, you're looking at the CBC, the white cell count, ESR, and CRP, special types of proteins which can be elevated in the setting of infection, and infection is a great mimicker of brain cancer in individuals. When there's a presentation, signs and symptoms suggestive of a cancer, patient shows up, you do a scan, and based on the lesion, they have a fever, elevated white cell count, CRP, ESR, you have to be thinking that it's more infection affecting the brain and not a tumor. Tumor markers are important, especially in the setting of investigation, if this lesion you're seeing within the brain is actually metastasis from elsewhere. This diagrams are pictures showing the CT scanner on the left and the MRI on the right. Just to get a little bit into some imaging. So on the left, we have a CT scan, less detail compared to the MRI, but some of the advantages of the CT scan is that blood shows up more readily. In this case, this tumor, frontal in origin and midline. The structure is called corpus callosum. There was actually a bleed within the tumor which extended into the ventricles. That's the white you're seeing on the scan. On the right, there's an MRI image of the same tumor. You can appreciate that it shows the tumor much more defined on the MRI study, but blood is not as visible. But radiologists and the neurosurgeon have ways in which they can analyze and detect blood. But to an individual in the ER, emergency room physician, CT, much quicker study to get and can show up the pathology, rule out strokes and other conditions quickly, and get the person onto the next stage of management. This is a MRI of the same tumor, but a different type of sequence to show the tumor. This is axial and coronal view, a view as though you're looking from the foot of the patient, and on the right is a view as though you're looking from in front. That's a coronal view. It actually shows a left-sided tumor with the white. You can see the white and dark grayish area. That's within the left frontal lobe of this patient. I believe this tumor was a glioblastoma, the short of it. And the patient has some amount of language impairment and impairment in motor function. On the left, we have the case of a left-sided temporal and occipital lobe metastasis. You can see areas of dark and white. Basically represents a cyst and a solid area more of the tumor, and a solid component here of the tumor. Multiple tumors on a scan, especially in the cyst setting of a patient with a known primary cancer elsewhere in the body, is metastasis until proven otherwise. This was a case, I believe, of colorectal cancer, which metastasized to the brain. On the right is an MRI. On the right cerebellar hemisphere, in the right cerebellar hemisphere, there's a solid tumor. In this case, in an adult, spread to the cerebellum is always metastasis until proven otherwise. axial and sagittal images, again, looking from the foot of the patient and looking from the side, on the right side. There's a tumor, might be difficult to appreciate, but the red arrows kind of point to where the tumor is, the cancer is. And in front of it shows the ventricle, which is dilated, the fourth ventricle in this case. So this patient also had hydrocephalus, 14-year-old, and it was a medulloblastoma after intervention, pathology, etc. In kids, supratentorial tumors, now these tend to be less common. Infratentorial, if we were to go back to the side, is in this area in the cerebellum, which we refer to that as infratentorial. Those are cancers in this area of the body is more common in kids as opposed to above, which is supratentorial. So in this case, you have a big glioma or astrocytoma on the right side, affecting the temporal lobe primarily. And on the image on the right, you have a large tumor, in this case, a grade 2 glioma affecting the left frontal lobe. So apart from imaging, which can give a good idea of what you're dealing with, biopsy is important. Now, biopsy could occur of the brain tumor itself, or the cancer in the case of metastasis, which is located outside of the brain. In terms of biopsy in the brain, it could be a needle, on the image guidance, we call that stereotactic biopsies, or tumor excision, which could just be removal of a portion of the tumor or all of the disease once possible. This is accomplished through a craniotomy, which you incise the scalp, remove the skull to get to the brain. There are certain situations where biopsy is not necessary. For example, if you had in a kid tumor involved in the brainstem, those are, most commonly diffuse gliomas, and tumors in that area, difficult to biopsy, especially in terms of preventing neurological deficits. And you can almost always diagnose that tumor just based on imaging and can proceed to further treatment. So these images just kind of give an idea of what a craniotomy involves. The image far left, you can see the scalp has been incised, elevated, showing the skull. We're making holes in the skull. The next image shows holes completed. In this case, this was what we call a bifrontal craniotomy being done, so the holes will be connected in order to lift the skull or the bone out. The image on the far right, not necessarily the same surgery, but just to depict when the skull is removed and the dura, the shiny piece of tissue here is reflected. You can see the brain underneath. Frontal lobe, temporal lobe, parietal lobe. Here was a right-sided craniotomy. We call this a pterygoidal craniotomy. These images just depict surgery on a young patient many years ago, I believe. Right-sided temporal glioma, large, open the skull. You can see the bulging brain because of the tumor. Close up, this pale area of the brain is the abnormality, large tumor. This is normal brain behind. After resection, this is a cavity here, left behind, and dura approximated, just to cover the brain. This was completed in terms of closure. And this was, I believe this was a grade 2 glioma or grade 3. So about treatment, it's multidisciplinary, involves a neurosurgeon, the pathologist, medical oncologist, radiation oncologist. Simplicity, the neurosurgeon operates, the pathologist looks at the brain specimen, the tumor specimen to analyze it, do certain tests on it. Medical oncologist, the person responsible for chemotherapy, medications to try and give intravenously to kill the tumor. Radiation oncologist, giving radiation to help destroy tumor cells. Other specialties which can be quite significant in the management: general surgeon, surgical oncologist, cardiothoracic surgeon, gynecologist, hematologist, all depending on if this is some cancer originating in one of the organs outside of the brains, but spread to the brain. So you may need them in terms of local control of primary malignancy. Surgery often depends on the patient's clinical status. Patient could present to the emergency department, life-threatening state because of the mass effect from the cancer, need emergency surgery, or they could present similar state but extensive disease to the brain, metastasis from uncontrolled metastasis. Patient is of poor prognosis. Surgery might not be undertaken in that case. Surgery also depends on the number and size of brain tumors present. In the case of metastasis, which are small, usually less than 3 centimeters, these patients, you can know what the primary is, and as it pertains to the brain, you don't operate, you just proceed on to chemotherapy and radiation. Location is also important. The tumor is in a readily accessible area, you can proceed with surgery, but it might be in a less accessible area, and you have to utilize other options in terms of getting tumor specimen, such as a needle biopsy. Chemotherapy and radiation, I won't speak much here, I leave that more to the medical oncologist and radiation oncologist, but this type of intervention utilized typically after brain cancer treatment from surgery. Could be whole brain radiation that is employed, or something called gamma knife, which is a precise high dose type of radiation that is delivered to the brain to kill the tumor. Usually when the tumor size is less than 3 centimeters, or after resection of a tumor and you have some residual, or you want to take care of any tumor cells that might be left behind, not seen with the eyes or the microscope in the tumor bed. After resection, gamma knife could be utilized to kill those cells to try and improve what we call disease-free survival. Immunotherapy can be important. Medications to try and boost the immune system to help the body's natural ability to fight the cancer. Some patients may qualify for clinical trials, especially in glioblastoma, which is so hard to treat. And if the clinical trial is successful, this might have a significant impact in that patient's survival. Rehabilitation, definitely important, helps the patient cope with whatever deficits that occurred because of the brain cancer or treatment, and try to get them as much as possible back to what was their regular routine before the cancer diagnosis. What are the alternative therapies? Not many that is within mainstream data. Prayer always important, always works. Faith is important to persons, and that can make a difference to the survivability. There are other things: nutrition, alteration. There's a up-and-coming field, probably becoming more mainstream, integrative oncologists. Their aim is to utilize conventional treatments in cancer, as well as unconventional therapies to try and help in the patient's ability to cope, deal with side effects, or even in some cases, prolong survival. There are some people who give, dramatic results, but I think more established data is required before, recommendations can be made, at least in this forum, from, persons like myself. So what's the prognosis? Really depends on the type of cancer. Brain cancer, that's metastasis. The average survival is 8 months. You always have persons who can beat the odds and survive longer, but this tends to be what we see. Glioblastoma, 10 to 14 months, oftentimes much shorter. Long-term survivals do occur, but are rare, greater than 2 or 5 years. In the management of glioblastoma, what's important is maximal safe resection when possible, associated with chemoradiation. This improves progression-free survival. But surgery is really helpful in persons from the get-go who are like bedridden, poor performance status, significant neurological impairment pre-existing. So are there other, this was like a whirlwind through brain cancers. It's a big topic. I'm willing and open to try and address any questions that you might have.
Anyone has any questions, you can either go ahead and unmute your mic and ask the questions, or you can type it in the chat if you wish.
You could go ahead and read the chat for any questions that I may have put.
Hi, Dr. Burrows. In terms of biopsies, what is the risk of getting an infection or dying from it? I'm really interested in hearing more about that.
Well, we tend to quote general figures, but it all depends on where you're biopsying. Some areas are far less risky to biopsy than others. In general, if you're doing what we call freehand or needle biopsy without image guidance or stereotactic frame, that can be more risky in terms of how your hand, the surgeon's hand could shift. But with experience and training, that tends to not occur. But the common thing is what we call a frame, stereotactic frame, to cut down on the risk of doing a needle biopsy and going somewhere you shouldn't. Risk of infection is pretty low. We do a lot in terms of to try and mitigate the risk of infection. And oftentimes when a biopsy is done, really and truly, the risk of the cancer being undiagnosed and treated is far greater than the risk of the procedure itself. So it's not something that's insignificant. However, to do nothing is oftentimes can be of greater risk to the patient in terms of survival or in terms of neurological deficit. I hope that answers a question somewhat. I don't necessarily want to give figures, because if I were to say to you less than 2% of cases, sometimes if a patient drops in that 2% of cases, for them, that's 100% and significant, right? But the bottom line is much lower risk than people would believe.
Thank you so much. So in terms of like downtime, if I were to do a biopsy, how long would I be on bed rest, or will I be on bed rest? I'm not sure. I'm new to this stuff.
Depends on how the patient looks, what they're presenting with. The type of biopsy being done, like I've mentioned before, it could be a needle or it could be a craniotomy, one of those pictures that you see big incision, skull open, and you're trying to get all the tumor out. Oftentimes the downtime is quite short, especially with needle biopsies. In terms of larger operations where you're trying to debulk the tumor or get as much of the tumor out, a patient who has a good pre-existing performance status, they were bedridden, didn't have significant neurological deficits to begin with. If you do a craniotomy and remove the tumor, downtime could be as short as a week within hospital, right? So it all depends on what the patient is actually presenting with.
Thank you so much. That's it from me. Thanks.
I have a question.
I do have a question, please.
Go ahead.
One of the symptoms was headaches, and I know, is there a way to differentiate between a person who's just having like constant migraines versus someone who should really go out and say, I need to get my brain checked, I may have a tumor?
Well, basically taking what we call a headache history. The migraines, you can have atypical migraines, but commonly, you can have triggers, whether eating certain foods, certain stressful situation where you can definitely associate the headache to a trigger that's more likely to be a benign type of thing, situation you're dealing with, especially if it's something that you are suffering from teenage years or early adulthood. Any headache once you're above the age of 50 should be evaluated. But headaches, that person's migraine tends to be something that's chronic. It's the usual degree. Persons can predict exactly how the headache affects them, what makes it better. With a headache from a brain tumor, that type of headache might change. If they had migraines, the character of the headache might change. So they might be able to say, hey, something is different about this headache this time. Much more severe than normal, lasting longer than normal. Worse in the morning, as I said. Vomiting occurs, nausea occurs. Once you're having things like that, no, some migraine can be really bad with persons and they have nausea and vomiting. But if that's what your typical thing is, and usual migraine medications work, darkness, etc., it works, you might not be as concerned this is a brain tumor. But if there's a situation where you never had that type of predisposition, and then you're now seeing yourself laid down, in excruciating pain, throwing up, that should be checked out. So I'm hoping that helps to answer your question. It's really just a change in the character of the headache. Migraines tend to be diagnosed much earlier and unilateral. You may have something called tension headaches. It's associated with stress or doing certain activities. Those are less concerning. But when you're just getting a headache out of nowhere and it's persisting and you never normally have a headache, reasonable to just get a medical evaluation.
Thank you so much, Dr. Burrows.
Any other questions?
Yes, good night. I have a question, or more so would like to find out more about preventative measures. You had mentioned earlier in your discussion about having diet and certain things like fertilizers or common things in our surroundings being a precursor to having symptoms or having the disease of cancer. Can you speak more on how we can prevent, or at least put ourselves in a better position where we can not have an incident, or if it can be prevented, being able to know what to do to ensure that we live healthier lives. Thank you.
Okay, thanks for the question. So I hope the slide wasn't misleading. What I was trying to communicate with this slide was there are certain compounds that are carcinogenic, right? And has been found in certain foods. So, there's a thought that, okay, if this thing is known to cause cancer, we're finding it in certain foods, so sausages, bacon, so on. Back in the day, I'm not sure if they do much of it now. They would utilize nitrites to help prevent the growth of certain bacteria within the meat, right? And because it's known that those nitrites might get converted to some of those carcinogenic compounds, there is no real link in terms of things in the environment that cause brain cancer you would avoid. No, the only one thing that has been kind of shown to possibly predispose to development of brain cancer or cancer in general is exposure to radiation, right? So, and of course, this is not common day-to-day activity. Persons in the medical field, if you are not wearing adequate protective clothing and you're in certain environments involving radiation, those persons could be at risk. So if you're in that situation, then obviously ensure that you are wearing protective gear. In some cases, the requirement in some environments, working environments, is that they will wear a type of tag that can detect how much radiation that person has been exposed to, like a cumulative detection. So I'm not certain, not many places employ it, hospitals employ it, but it should be done, especially radiation technologists. These people tend to wear these special badges or tags which tracks the amount of radiation they're exposed to. So those are the preventative things that one could do if you are working in that field. Persons who have a cancer and they have to undergo radiation treatment, that can predispose them to radiation, to cancer developing later on, especially if they get brain radiation, right? But that's not like the everyday occurrence to the average person without the disease. So all I can say is there's nothing proven to say, some change in your diet. And apart from avoiding unnecessary exposure to radiation, nothing else that you can do. There's certain genetic predisposition. I mentioned some of that, but these conditions are very rare.
Hello, good evening. I have a question. Good evening, Madam President.
Good evening.
Good evening, everyone. Yeah, I have a nephew that lives over in the States, and we were told that he had a stroke. So eventually I went to visit him. He was still in the hospital, me and my family, and the doctor came in and he wanted to go over some stuff with him. So he gave him the okay, told him I'm his aunt. And he brought this machine and he was showing us what was happening in his brain. And what he was showing me, I wasn't too clear because it was so small, but he said this thing is growing rapidly. And one of your slides, which you showed, the tumor, it was more clearer there. But what I want to know, could a tumor make them, could it act like a stroke? Yeah. That's what
in fact, that was one of the things I mentioned. There are a proportion of persons when they are taken to the hospital, especially in elderly people over the age of 60, the thought is that it's a stroke that they're suffering from, and it turns out to be a brain tumor. Person basically was suffering from it. And let's say they just reach a tipping point. Sometimes there's bleeding within the tumor, and that's what caused them to have the rapid decline. They're brought into hospital as though they had a stroke, but then the scans, the relevant investigation, shows that yes, you did bleed. Seems like it's a stroke, but the underlying problem to cause the bleed was a tumor. So yeah, that's one of the presenting symptoms or signs.
Oh, okay. They operated and they apparently they took it out, but what the doctor also said, I have high blood and my husband has it. It never bothered him. He never had it. He was always someone went to the gym, exercise, all the time. He had a stroke while he was in the States. And what he said is we were like, you didn't feel anything. And he said, no, I just felt my arm. One of his arm, I think, was cold. Started just like a catch cold. So he thought because he was exposed, like it was winter time, just before the winter. So he said that's the only thing he felt differently in his body. When his arm used to feel like it's a little cold, like he caught a cold on it or something. But he said, sorry?
The term that paresthesia, abnormal sensation. Yeah, so that was actually on my slide as well, yeah. But a patient can have that. The most common reason is a stroke, right? Most common. But it's just that some persons who have that, the problem could actually be a brain tumor. But the scans tend to be quite, you do a CT, you do an MRI, etc. They tend to be quite specific in terms of differentiating what might be a stroke, what might be a tumor. And in cases where there is still doubt, that's where biopsy becomes important.
Okay, because his sister saw him. They were on the ship going to the States just before it happened. And she said, I saw you turning your head kind of strange. And he didn't know what she was talking about. And she was like, when you turn, it was like this strange way that he turned when he was talking to her and moving about. And he said, far as he was concerned, it was just normal, you see. But anyway, it turned out to be a stroke, and he's not been, like, it was what they call a mild stroke, but he's never been the same, you know.
Yeah.
Mhm.
Yeah. I think that one probably is pretty straightforward in terms of a stroke.
Right.
Sorry to hear about your nephew.
Yeah.
But hopefully you'll
Yeah.
do well.
Yeah. Yeah. I joined late, so certain things that you said already. I missed that. You see?
Oh, I see. I
Yeah.
see.
Yeah. Okay. Thanks again. All right.
Okay.
So there are two questions in the chat. And the first one is, how rare are hereditary brain cancers?
Oh, yeah. Very rare as hen's teeth, to be honest. I've never seen a case of those. I mean, neurofibromatosis, although it's rare, it's probably the one that, of all of them, probably the most common. Some of us have maybe seen someone suffering from that condition. They have a lot of lumps on the skin and spots. Still doesn't mean that they would develop a cancer, but they are at increased risk. So they're oftentimes, we as neurosurgeons, their tumors, what we call neurofibromas, tend to be benign. But when a patient is now showing symptoms of a neurological disease, weakness, etc., especially something that we can localize to the brain, we have to be thinking that they're developing, a glioma or astrocytoma. And I believe in my residency, I did come across one case. But apart from neurofibromatosis, the others, very, very rare. Probably 1 in a million, but you can't quote me on that figure.
Okay, thank you. And the next question is, person would like to know, if brain cancer is caught early, what is normally the survival rate?
It depends on the cancer and the age group of the person. In general, the prognosis for brain cancer, in general, you probably would find about 60% alive at 5 years. If the cancer, though caught early, is a high-grade cancer like glioblastoma in an adult, unfortunately, with the best of treatment, they might not survive more than 15 months. In my practice, especially in terms of the Caribbean or the West Indies, oftentimes they don't pass 8 months, despite maximal surgical resection, chemoradiation. So that's the type of situation you deal with. Metastatic cancer, again, that might have a very short survival, though caught early, 8 months. In kids, when they develop certain types of cancers, they may be 44 to 74 months in terms of survival, the best of treatment. So it's not very optimistic with brain cancers, but the thing about it is that you do have people who fall into the category of long-term survivors, right? And that is persons who are living with the disease, having been treated, greater than 5 years. But that is rare. I personally, in my practice, have come across a glioblastoma living that long. Low-grade gliomas tend to have the best in terms of prognosis when caught early and treated. 80% or more could be alive at 5 years. So out of all of them, the cancer would have to be low-grade when diagnosed to give the best possibility of 5-year survival. Was that answer? Okay.
Okay.
Any other questions in the chat or something someone wants to voice?
No, that's all in the chat for right now, at least. Anyone else have any other questions? Well, if there are no other questions, I guess we will, at this point, thank you, Dr. Burrows, for your very informative presentation. I think, well, for me, this is, I think, the first time I've ever seen a presentation on brain cancer. So good job. A lot of big words, but I guess at the end of the day, we kind of knew what were the things to focus on, eh? So
Yes.
yeah, so thank you very much for your presentation and your time this evening with us. We really appreciate it. And we hope that you'll come again.
Yes,
And
thanks for having me. And the one thing I would say is that, probably I hope that in the coming years, we can do something in terms of capturing the data in terms of the prevalence and incidence of cancer here, brain cancer here. It was quite interesting, at least with the data that I found from the cancer registry, that, we have if it can be trusted, obviously it's a small sample, but females tend to be, the ones who suffer from brain cancers compared to the men, and higher grades at that. So if that actually is holding to be true in a small population of the Bahamas, that is something worthwhile investigating and studying, because that's not what's seen in the rest of the world. So there could be something trending along in the Bahamian gene pool that is unknown, and might be important in us being able to, assess, and might make a difference in going forward in terms of treatment here.
yeah, that is actually very interesting. Yes. I guess it would be interesting to see where those numbers go in the near future. Yeah, I guess we'll stay tuned to hear more of that from you at your next presentation.
But I guess I'd have to work with the cancer registry to see what,
Yeah.
what we can do.
Do you see a lot of occurrences of brain cancer here in the Bahamas? Is there a high occurrence, would you say, or not necessarily?
For the population size, I would say it is. I've been here been back to the Bahamas, because I was here many years ago, but been back just over a year now. And I guess I could count about 5 cases, and that's just my practice. There are other neurosurgeons around. So for a population size, that can be quite significant. But it would probably take some amount of collaborative effort to get a handle on it. But just off of what we call anecdotal evidence, it's quite a few cases, right? Especially metastatic.
Yeah. Mm-hmm. Okay. All right. Well, thank you once again for joining us tonight. And I guess we'll stay tuned for more on that in the coming months or years, I guess. And we wish you well in your practice, and welcome back.
Okay. Thanks a lot for having me again.
Yes, thank you. Before we close out for everyone else, does anyone have any birthdays, anniversaries, milestones that they'd like to share with the group? It's an open floor at the moment. Anyone wanting to share? I guess not. Okay, so then I guess we will close out the meeting, and thank you all for joining us tonight. And stay tuned as it relates to whether or not we'll have a meeting next month. We'll post that very early so that you have enough time to plan to join us. But thank you again, Dr. Burrows, and thank you all for joining. And everyone have a good evening and be safe.
You too. Thank you.
Good evening, everybody.
Good night.
Good night. Good night.